Good morning, everyone. This is Cindy Groniger from Cancer Bridge. We're going to take a few more minutes to allow people to join the webinar, but we should be starting here within the next couple minutes. Thanks for your patience. Okay, good morning, everyone. Again, this is Cindy Groniger from Cancer Bridge. I want to thank everyone for joining us today. In recognition of Breast Cancer Awareness Month, Dr. Mitva Patel will be presenting breast screening in 2018, what's new and what you need to know. Before introducing Dr. Patel, I would like to take a few minutes to remind everyone of the Cancer Bridge service provided by your employer and to those that have joined us that might not know fully what Cancer Bridge provides. When you hear those three words, you have cancer, your life changes, your relationships change, and you feel critical decisions need to be made. This is where Cancer Bridge can help you through this emotional time. We provide immediate expert guidance at a time when your emotions are high and your information is low. Our services provides the benefit of knowledge, information, and guidance through our oncology nurses and speaking to physicians who are experts in your specific cancer. Calling Cancer Bridge is a very simple process. You would call our toll-free number, which is 855-366-7700. Your call is answered immediately by an oncology nurse who will triage the call, answer your questions on the type of cancer you're referring to, and provide you the opportunity to speak to a cancer expert and or connect you to the right resource. Once, if you have chosen to talk to a specialist, our oncology nurse will follow up with the caller following that call. It could be the next day. We do try to have our cancer experts call you within 24 hours, but due to some schedule conflicts at times, it could be a little bit, a little bit longer than 24 hours, but not much. Once you've had a call with a specialist, like I say, the oncology nurse will follow back up. So Cancer Bridge provides you and your family members with someone who's knowledgeable and who will listen. And we provide rapid access to an expert, like I've said, in your specific cancer. You receive an avenue that helps obtain a broader understanding about your cancer, and then guidance on next steps in avoiding mistakes, navigating you through the healthcare system, as well as providing immediate answers during a time of crisis. Who has access to Cancer Bridge? As you can see on this slide, parents, parents-in-laws, siblings, spouse and or partner, children, and I'm trying to, oops, sorry. But anyway, that's everyone in your immediate family members are included. All we need is your an employee ID number when whoever calls and your name. So some important facts to think about on a typical general practitioner or oncologist that cannot provide the Cancer Bridge services. Our research shows that there are over 200 types of cancer, and that number continues to grow. So community doctors are typically generalists with a basic knowledge of the most common cancers and don't have easy access to expertise like Dr. Patel. Our cancer experts are each invested in one particular cancer type. They know all the presentations and the latest best treatments for that cancer. They evaluate and treat only patients with that cancer and then advise the community oncologist regarding that cancer. More importantly, they perform and publish research, lecture around the world, which enables them to teach medical students, residents, and fellows on their specific cancer. Our experts know and network with other experts across the world who specialize in the same type of cancer. To learn further about Cancer Bridge, please visit our website at www.mycancerbridge.com or speak to your HR team. Throughout the webinar, you might have questions for our Q&A session. You can ask them in the questions panel in the GoToWebinar. If you think of questions once the Q&A is over, please email them to the questions@mycancerbridge.com, and we will get that response to you from Dr. Patel and send that back to you. A recording of the webinar will be posted to YouTube and the Cancer Bridge website in the next few days. So now I would like to introduce Dr. Mitva Patel. Dr. Patel is a radiologist with a focus in breast imaging. She received her medical degree from Michigan State College of Medicine. Dr. Patel completed her radiology residency at the Henry Ford Hospital in Michigan and also completed a women's imaging fellowship at the University of Pittsburgh Medical Center. She is currently an assistant professor of radiology at the Ohio State University James Cancer Hospital and Solove Research Institute. She has an interest in patient, physician, and resident education and is currently the director of the Breast Fellowship Program at OSU. It is my pleasure to welcome Dr. Patel.
Okay, thank you. Today I'm going to be talking about what's new in breast imaging in 2018 and what you need to know. Okay, so let's first talk about why do we screen for breast cancer? Well, unfortunately, 1 in 8 women will be diagnosed with breast cancer in their lifetime. The incidence of breast cancer increases with age. A woman in her 20s has about a 1 in 20,000 chance of developing breast cancer, and as a woman ages, it increases. In the 40s, it's about 1 in 200, and by the time a woman is in her 80s, it's about 1 in 10. But the entire lifetime risk is 1 in 8 women. So there's a high prevalence of breast cancer, as I've just talked about. There's also an improved outcome by treating during the asymptomatic period. So finding the breast cancer before it's spread to the rest of the body. And those two things together, there's a significant impact on public health. So that's why we screen for breast cancer. Multiple studies have shown there's a mortality reduction when you use screening mammography. There's approximately a 24% mortality reduction secondary to screening. There has been some recent controversy, though, as to when to start screening. So what age to start screening and how often to get a screening mammogram. If a patient does a Google search, you can get many different recommendations and it can be very confusing. A woman who does a search might see that some societies recommend starting at the age of 40. Others say 45. There's even some recommendations to wait until you're 50. The interval as to how often you should screen. Some say annual and some say every other year. So it can be very confusing. This can be confusing also to other ordering physicians. So why are there different recommendations? There's little disagreement among experts around the world that screening mammography actually saves lives. If you catch a breast cancer in the early stages, most often stage 0 or 1, there's a very high survival rate. But if breast cancer has spread to the rest of the body, unfortunately the survival rate drops significantly. So the different screening recommendations out there, what differs depends on the greatest relative value that the committee doing the recommendation places on certain things. So they look at things like stress. So the stress a woman undergoes if she's asked to come back for some additional views or asked to have a biopsy and it doesn't end up being cancer, the cost to the system. So those additional tests and biopsies can cost the system. The idea of overdiagnosis. So overdiagnosis is finding a breast cancer that is very slow growing and may not actually cause any symptoms, and it may not actually kill a woman. The only way, though, to know if a breast cancer is the slow growing one or the one that's aggressive is to not treat it and see what happens. And that right now is not an option. We can't just look at a mammogram and know whether this is a kind of breast cancer that is aggressive and going to spread or one that is just going to be slow growing. Likely only 6.5% of breast cancers that are identified would have remained symptom-free. So in practice, the probability of an individual woman's life being saved is double that of being overdiagnosed. And of course, there's false positives. Like I said, sometimes we recommend additional tests and biopsies, and they don't end up being breast cancer. So groups such as the American Cancer Society, which have placed the most weight on minimizing challenges for women associated with some of the stress, so the overdiagnosis, false positive readings, additional procedures that can cause stress, recommend starting at age 45 annually and then transitioning to screening every 2 years at the age of 55. Groups that are focused on minimizing biopsies, repeat scans, basically trying to keep the cost down, recommend starting age 50 and screening every other year. And this includes the U.S. Preventive Task Force, which is a recommendation from them to start at age 50 and every other year. The American College of Radiology and the Society of Breast Imaging place the most emphasis on what's been shown to save the most possible number of lives, and that is annual screening mammogram starting at the age of 40. So why should we screen at age 40 and get a mammogram every year? Well, 1 in 6 breast cancers occur in women aged 40 to 49. And unfortunately, those cancers can be more aggressive. And because those women are young and might have a more aggressive type of cancer, they have the most number of years of life that could be lost. So 40% of all of the years of life saved by mammography are among women in their 40s. So that's why we think that it's time to end the confusion and start screening at the age of 40 and get a screening mammogram every year. Okay, so the next thing that patients often wonder if they're going to get a mammogram every year starting at age 40 is how much radiation am I exposing my body to? A screening mammogram is equivalent to 0.4 millisieverts of radiation. Now that number may not mean anything to you. It doesn't mean anything to a lot of physicians. So I like to put it into to terms that patients can understand. 0.4 millisieverts of radiation is the same amount of radiation that a woman receives by just living 3 months in Ohio. It's the 3 months of background radiation that you might get from just the air you breathe, the food you eat, the buildings you enter. We use the term ALARA, as low as reasonably possible. So we know that a woman is being exposed to a small amount of radiation, but we think that that amount of radiation is worth it in order to possibly identify a cancer that might save her life. Another thing that a lot of patients ask is, how painful is a mammogram? The anticipated pain is actually one of the most common complaints and most common reasons that women give for avoiding getting a mammogram. The good news is not everybody has pain during the test, and often if they do have some pain, it only lasts for a short period of time. Most women, when we do a survey, say that they have very little to no pain during a mammogram. Only a few notice that it is very painful. And the ones that do have pain say that it disappears almost immediately after the procedure. Okay, so what exactly is a screening mammogram? A screening mammogram uses X-rays to image the breast in order to identify an abnormality that could represent breast cancer. It's used to evaluate asymptomatic people, so women who do not have any symptoms at the time, and we're just looking for a cancer. Most often, the radiologist doesn't see the images until after the patient has left the department, and she's notified of her results later. The technologist will obtain 2 views of each breast. The first view is the cranial caudal view, okay, and the other view is the medial lateral oblique view. This is what the mammogram looks like for the radiologist, and this is how we project it on our screen. This is the right CC view, the left CC view, that's cranial caudal, and the medial lateral oblique on the right, and the left medial lateral oblique. We typically place little tiny stickers that have a metallic BB to mark the nipples. And this is the outer portion of the breast and the inner portion of the breast, and the superior portion of the breast and the lower portion of the breast. Okay. So what do radiologists look for? We look for new masses. We look for microcalcifications, which are these small white dots. And we look for tissue distortion. So a cancer sometimes will pull in normal tissue, and you can see these lines of normal tissue radiating towards a cancer that's pulling in normal tissue. We also talk about the patient's breast density. So there are 4 main categories of breast density, and they range from patients that have very little fibroglandular tissue. This fibroglandular tissue is white on a mammogram, and fat is dark on a mammogram. So it ranges from mostly fatty tissue with very little fibroglandular tissue all the way to most of the breast being fibroglandular tissue and very little fatty tissue. Now, a cancer is going to be white on a mammogram. So as you can imagine, a cancer that is white on a mammogram might be missed on extremely dense breast tissue, but it's unlikely that it's missed on a fatty replaced tissue. So for that reason, women in Ohio and in approximately half of the states, it's a law that they're required that we notify patients when they fall into these 2 categories, heterogeneously dense and extremely dense, so that a patient knows that mammography may be missing a cancer. So a copy of the report goes to the ordering physician, and then the patient receives a letter explaining the results of their exam, their breast density, and the recommended follow-up. Okay, so what do you do if you have symptoms? This is a nice worldwide campaign called Know Your Lemons, with some visuals of some findings that you might have if you have breast cancer. Now, certainly if you have some of these symptoms, there are benign causes to some of these symptoms, but if you have a new lump or bump, nipple discharge, dimpling of the skin, nipple retraction, any of these findings, then you would get a diagnostic mammogram. So this is a symptom, so a woman would not get a screening mammogram. Now, a diagnostic mammogram is performed under supervision of a radiologist, so they can order additional specialized views, and they can come up with a recommendation or a plan for your symptoms before you leave, okay? It tends to be a longer exam time, and sometimes it's not fully covered by insurance. So I think that's important for patients to know. Screening mammograms are almost always covered 100% by insurance, but sometimes a diagnostic mammogram is not completely covered. And I don't know why, but I think that it's important for patients just to know. So again, it's done instead of a screening mammogram on a symptomatic patient if you have a lump, pain, or nipple discharge. It's also done on a patient who had an abnormality detected on a screening mammogram. So if we see something on a screening mammogram, we're going to ask a patient to come back for additional views and then perform a diagnostic mammogram so we can evaluate that possible abnormality. And this is a case here where this patient had a palpable finding on her left breast. So we sometimes use a triangular marker to mark where the patient is palpating a lump. In this case, she has these microcalcifications in her palpable area of pain. And this is the other view too. The triangular marker and these microcalcifications here. So the radiologist, we can order magnification views so we can get a better look at those microcalcifications. In this case, where she was feeling this lump, there were suspicious microcalcifications, and we recommended a biopsy, and this ended up being invasive ductal carcinoma, so this ended up being a malignancy. We can also do a mammogram. We can also do additional spot compression mammograms. So in this case, there's a BB marker marking a palpable finding. You can see there's a mass here. Sometimes we take a paddle and press the tissue on a mammogram. If the tissue spreads out, it's probably just some overlapping normal tissue. But if the mass stays, it's probably a real finding. And we can also sometimes do ultrasound too. And so in this case, this mass here, they did an ultrasound, and this is a benign cyst. And a cyst never becomes cancer. And this is a benign finding, okay? That brings me to ultrasound. This is another tool that radiologists have. Breast ultrasound can be performed with a diagnostic mammogram. Sometimes there's an area that we are questioning on a mammogram, and we can do a focused ultrasound, so just a specific area within the breast. There is no radiation for ultrasound, and the patient is not in compression. So we use it to try to determine whether something is cystic or solid. Again, something that is just a simple cyst is not suspicious, and we don't have to do any further imaging or tests on that. But if it's a solid mass, sometimes we can try to determine if the solid mass is something that's benign, a benign mass within her breast, or something that we're more worried about. We also use breast ultrasound alone if a woman is under 30 and she palpates a mass. So we try not to do a mammogram for those cases because we want to limit radiation for those young women. Their breast density, they might be in the heterogeneously dense or extremely dense category, and so the mammogram may not be as helpful. And we just want to limit the amount of radiation. Also, the incidence of breast cancer is lower at that age. We can also use breast ultrasound to guide for biopsies, which most breast radiologists perform as well. The next tool I wanted to talk about is breast MRI. So for breast MRI, the patient is placed on her stomach, and an IV is placed, and she obtains, she's given contrast. And so this is gadolinium is the type of contrast, and that's given through an IV. And then we take MR images, and we're looking for an area of enhancement. The idea is that as a tumor grows, it recruits blood vessels, okay, because it's growing very fast, and so it's recruiting blood vessels so that it can continue to grow, and that's what we're looking for on a breast MRI. We're looking for an area of enhancement, okay? It is not affected by breast density, and there's no radiation. So this is a case where, you know, on the 2D mammogram, you don't really see the mass that well. We take images without contrast and then after contrast, and you can see this enhancing mass, which was a breast cancer. So who should get an MRI? Patients that have a newly diagnosed breast cancer sometimes get a preoperative MRI if they're trying to decide whether they can get a lumpectomy or whether there's a lot of disease within the breast and they need a mastectomy. Sometimes we do MRI to assess response to chemotherapy. So women who have a new breast cancer, before they go to surgery, sometimes they're given chemotherapy to shrink a tumor. And we can take a look at it with breast MRI to see if the tumor is shrinking appropriately. And if it's not, they can adjust the chemotherapy. Breast MR can also be performed if there's a question of a breast implant rupture, a silicone breast implant rupture. So we do mammography for breast implants, and if there's some irregularity on the mammogram and there's a question of implant rupture, we can do a breast MRI to see if there's any silicone outside of the implant. This specific test is not to identify a breast cancer. There's different sequences, but it's just to evaluate for silicone implant rupture. And the most common use for breast MRI is screening for high-risk patients. So the American College of Radiology recommends that women assess their risk of breast cancer at the age of 30. so we can identify who is a high-risk patient. And this can be done by your family physician, your internal medicine or your family practice physician. And there's also tools that patients can use too. There are high-risk online calculators where you can input your age, weight, other factors such as family history, history of prior biopsies, and you can assess your risk. And if a patient has over a 20% calculated lifetime risk of breast cancer, they're considered high risk. And if they're considered high risk, we recommend annual mammography starting at the age of 30 and annual MR starting at age of 30. The MR is not a substitute for mammography. So if you're 30 and above, we recommend an annual MRI and an annual mammogram. Women who have a personal history of breast cancer and dense breast tissue, or those that were diagnosed very early, like before age 50, annual surveillance with breast MRI is also recommended. So as I said, MRI is a supplemental study of choice for all high-risk patients. It is a very sensitive test, about 97% sensitivity, and that means that it's very unlikely if you have a breast MRI that we are going to miss a breast cancer. Okay, it detects approximately 15 additional cancers per 1,000 women screened who are high risk, and that's women who've had a normal mammogram and normal screening ultrasound. So if it is so good at detecting breast cancer, why don't we use it on everybody? Well, MR is not as accessible. We have fewer MR machines than we do mammography machines. It's a longer exam time. It takes about 45 minutes to get a breast MRI. The timing, if a patient is premenopausal, we have to time it at her second week of her menstrual cycle in order to minimize the hormonal effects in the breast. And they are also false positives. So sometimes we see things on a breast MRI, and we have to do additional tests and sometimes even additional biopsies, and it doesn't end up being a breast cancer. So, and one of the main reasons also is that it's a very costly exam. It costs at least $1,000 to $2,000, which is at least 10 times the cost of a mammogram. And so it's very costly to patients and to the system. So because of that, there is some interest and some research being done on shortening the breast MRI study. So normally we take about 10 sequences. Like I said, it takes about 45 minutes. And there's research being done on taking that scan time down to only 3 minutes. So like I said, the standard MRI is 30 to 45 minutes. And taking it down to a 3-minute scan with 3 sequences. And if this can be done and the cancer detection rate is the same, the reduced magnet time and the radiologist reading time, because there's fewer images, would make the MR much more affordable and potentially something that more women could have access to. Okay, something that we do have right now that's becoming widely available is tomosynthesis, or 3D mammography. Okay, so this uses this is an X-ray image, and the mammography machine moves in an arc and takes multiple high-resolution images. So it's just like a mammogram, but it's multiple slices through the breast. Okay, so why do we need to do this? Because 2D images have tissue superimposition, and that superimposed tissue can hide cancer, and it can also make normal tissue look like it is cancer. And so 3D mammography solves this problem by removing all the overlapping fibroglandular tissue. The exam is similar to a 2D mammogram. The breast is in compression in those same CC and MLO views, but the X-ray tube moves in an arc across the breast instead of being stationary. This is what it looks like, the tube moving. The total radiation dose is approximately equal to the mammogram. So right now, the FDA requires every patient to have a 2D mammogram. So if you're going to have a 3D mammogram, you have to have your 3D plus your 2D mammogram. So if you have both of those exposures, it's about double the amount of radiation. There is new technology out there that can take those tomosynthesis slices and fuse them together and make what's called a synthesized 2D mammogram, which is FDA approved, so that a woman doesn't need that 2D mammogram and 2D exposure. So if a patient gets the C-view, which is a synthesized 2D mammogram, and then the tomosynthesis slices, the 3D mammogram, they will have the same amount of radiation as a 2D mammogram, but they'll have the benefit of tomosynthesis. And tomosynthesis has better cancer detection and fewer callbacks on screening mammograms. So fewer times we have to ask a woman to come back from a screening mammogram for additional views. Okay? I don't know whether you were able to see that, whether this moved through. Sorry, this movie is not, let's see whether it's working. It's not working, but it slices through the breast and you can see a cancer better. So who would benefit from 3D mammography? Any woman can benefit, but I think the most benefit comes from women who fall into these two categories, scatterfibroglandular tissue and heterogeneously dense. 2D mammography is pretty good on fatty replaced as it is. However, again, 3D mammography can be of benefit, especially if a woman gets C-view and is not being radiated twice. And here is an example of a 2D mammogram. This is a slice from tomosynthesis, and you can see there is there's a mass, a suspicious mass here and some microcalcifications, and it's just much better seen on the tomosynthesis slice than the 2D mammogram. Okay. Okay, so let me talk about some future applications: screening whole breast ultrasound, contrast-enhanced mammography, and molecular breast imaging. So screening whole breast ultrasound introduces the idea of ultrasound as a screening tool. So a woman is asymptomatic, just like a screening mammogram, and this is a supplement to the annual mammogram. So before I had talked about a diagnostic ultrasound, and that's just a focused ultrasound on a certain area that we were worried about. This is an asymptomatic female, and we're scanning the whole breast in order to find a cancer. This has shown to improve the cancer detection rate in women with dense breasts beyond what a mammogram alone could find. Some places have automated systems, machines that specifically do this, that can acquire the whole breast within 10 minutes. Other places use just the regular ultrasound machine, and the technologist takes images of both breasts. Whole breast ultrasound or screening breast ultrasound may be useful in women with dense breasts because it is not affected by breast density and there's no radiation. It can detect an additional 3 to 4 cancers per 1,000 women screened. Now the limitation and the problem with whole breast ultrasound is, again, the false positive. So sometimes we are seeing things that don't end up being breast cancer, and we have to do additional tests, call the patient back and do additional tests. Sometimes we ask patients to come back for a 6-month follow-up. About up to 20% of cases in some places have 6-month follow-up where women are coming back every 6 months for a total of 2 years in order to make sure that the finding is actually benign and it's not something malignant. Also, only 10% of the cases that we recommend a biopsy on ultrasound end up being malignancy. So a lot of biopsies are being performed and they don't end up finding breast cancer. Okay, so that is one of the main limitations for whole breast ultrasound, screening breast ultrasound. Contrast-enhanced mammography is another tool that is out there. It's been around for about 10 years, but as the technique improves, more centers are starting to offer this. And this basically has the idea, just like MRI, it's assessing neovascularity. So this is essentially a mammogram with contrast. So CT contrast is injected, and the standard mammographic views are obtained, but instead of just one exposure, 2 exposures are taken. So you can't actually see contrast on a mammogram. So, but what we do is we take the normal mammogram And then we take a mammogram that's at a different energy level, that's closer to the contrast. And then we subtract away the tissue from the normal mammogram, and we're just left with the contrast. Okay, so here's a case here where you might not be able to see this cancer, but you can clearly see it on the subtraction view. Here's another case here where you can see a mass in the lateral right breast on the craniocaudal view, and you can see it on the subtraction view, but what you can't see on the 2D mammogram is this cancer here, which you can clearly see on the subtraction view for contrast mammography. And this is here in the lateral view too. The same mass which you could see on both imaging, and then you can't see this area on the 2D mammogram. Okay, and the last additional test that some radiologists have available is either gamma-specific breast imaging or molecular breast imaging. These two studies fall under the category of nuclear breast imaging. So a radio tracer is injected. So an IV is placed and a radio tracer is injected. Gamma-specific breast imaging uses technetium-99 sesame B, and we're looking for areas, what we call hotspots, so increased metabolic activity that is found with breast cancers. Okay, so 2 views of each breast are obtained. This is a specific machine. Each image takes about 5 to 10 minutes to acquire, and the whole scan time is about 40 minutes. So this might also be a helpful tool for women with dense breasts. This is a 2D mammogram, and this is an area of increased metabolic activity that's showing a breast cancer that you can't see on the 2D mammogram. Now, the problem right now with nuclear medicine and gamma-specific breast imaging is that it's a higher radiation dose that's limiting its use. The radiation dose is an injected dose, so the radiation is to not just the patient's breast, but it's to the colon and bladder, and it's a systemic radiation dose. Also, the resolution is lower. We may not be able to see masses under 1 centimeter, and we really want to catch a cancer as soon as possible and often find masses under 1 centimeter on mammography and ultrasound. Last thing I want to say is beware of misinformation on the internet. I've often come across things that are absolutely incorrect. One example is there's a lot of information out there on thermograms, which there's no scientific data out there that thermography is a breast imaging tool that can, I should put this up, that can identify a breast cancer. When I've looked around on sites that describe thermography, they talk about the radiation dose associated with mammography, all of the drawbacks that I talked about that are associated with mammography, but that doesn't mean that thermography is the answer. There's no scientific proof showing that thermograms are better than mammography or an option to screen for breast cancer. And that's all I have to talk about today. So I'm open for questions.
Good afternoon. This is Sharon Steingass, and I'm going to moderate our question and answer section. So thank you, Dr. Patel. That was a fabulous presentation. Again, with it being Breast Cancer Awareness Month, it's the perfect time for us as women, or if you are a gentleman who's listening and have women in your life, a great time to remind people to get their screening mammograms done. So a couple of questions have come in that I'd like to pose to you. And the first has to deal with the fact that obviously women, we are not all the same size. And some women have very large breast tissue. And so talk to us a little bit about how to do breast imaging for women with very large breasts. And can you get a mammogram if you have a very large breast?
Sure, yes, absolutely. You can definitely get a mammogram no matter what your breast size is, okay? Women who have very large breasts that don't actually completely the breast doesn't fit on the mammography machine, the technologist will take a few more images to make sure that all of the tissue is covered, and they will just take multiple images to make sure that we're imaging all of the breast. The good news is that most often women who have larger breasts, most of the breast tissue is that fatty tissue rather than the fibroglandular tissue. So although it might be a little bit harder to obtain the images by the technologist, interpreting the exam is actually easier, and it's unlikely that we would be missing a breast cancer with those types of that type of tissue.
Okay, great. Thank you. So then the next question has to do with implants. Many women have implants, so you touched a little bit about doing imaging with implants. So this is really a two-part question.
Sure.
First, screening mammograms with implants, and then the second is doing a diagnostic mammogram with implants for somebody who has a history of breast cancer.
Okay. So the first question for screening mammogram, women who have implants definitely can get a screening mammogram. So what we do is we actually obtain two sets of images. One, we do what's called implant in place views. So we take an image of the tissue and the implant, so the whole breast. And then technologists go back and they do all the CC and the MLO views of what's called implant displaced views. So they push the implant back and they compress just the anterior tissue. And so we can get a good look of the tissue anterior to the implant. So yes, we can do screening mammograms on women who have implants, and we often do. And we are able to detect abnormalities on screening mammography as well. Now, your second question was women who have a history of breast cancer. So often women who have a history of breast cancer will get a diagnostic mammogram. Different centers keep women in what we call the diagnostic pool for a different varying time. Some centers, after a woman is diagnosed with breast cancer, we only do diagnostic imaging for 10 years after they're diagnosed. Some we do it for 5 years. But if you are still in that category where we're closely watching you and doing a diagnostic mammogram and not a screening mammogram, then you would just, again, get those implant in place views and displaced views. Now, women, like I said, women who have a history of dense breast tissue and a personal history of breast cancer, or women who have a breast cancer that was diagnosed early, I would recommend, again, talking to their breast surgeon or their primary care physician about whether supplemental screening with breast MRI to detect a breast cancer is necessary.
Okay, great. Early on in your discussion, you talked about the age at which people should start screening mammograms. And obviously, you talked about some controversy. In your opinion, do you know or do you have any projections about will the age for screening mammograms stay where it is, or do you think it will ever be lowered?
I think it will. I don't think that we will start screening routinely for an average risk woman under 40. We don't want to expose women who have an average risk and the incidence of breast cancer is lower in the 30s. We don't want to expose them with too much radiation. So I think, when I showed you the incidence of breast cancer and how it's lower in 20s and 30s, but it's about 1 in 200 for 40s. I think it's going to stay at 40s. But it's important that now the new recommendations are that everybody assess their risk at age 30. That's a relatively new statement and a new recommendation so that women who are higher risk can start earlier.
Okay, great. Yes, thank you. And then one last question. How do I get a screening mammogram? Do I need a doctor's order? Does my primary doctor have to refer me to a place to get a screening mammogram? How do I get one?
That's a great question. No, you can self-refer for a screening mammogram. Okay, so you don't have to wait to go to your doctor. If you're 40, you can if you are 40, you can self-refer. Now, if you have a symptom, like I said, and we were talking about a diagnostic mammogram, or if you think that you're high risk and you think that you are going to get a screening mammogram before 40 because you're high risk, that's going to need a doctor's order. But if you're 40 and over, you can self-refer and just call and schedule a mammogram, and you don't need a doctor's order.
Okay, and most hospitals can offer mammography, screening mammography. So it's a matter of just calling, finding out where screening mammography is offered, and then setting up an appointment. And some places now are being done in places where, again, women tend to frequent. So shopping malls and other places have mammography units, and there are also mobile mammography units that sometimes will travel around the city, especially during the month of October for Breast Cancer Awareness Month.
Absolutely. We want to make sure that mammograms are accessible for everybody.
Correct.
And so initiatives are being, are taking place so that women can get an annual mammogram every year.
Okay, great. Well, I think those are all of the questions that we've had. So thank you again for a fabulous discussion about breast cancer imaging, and gave everybody, I think, a really good overview of all of the various diagnostic techniques that are available, screening and diagnostic techniques that are available. Thank you.
Thank you.
Going to turn it back over to Cindy for anything else.
No, thank you so much, Dr. Patel. That was great information, great presentation. We really appreciate it. Again, if anybody has any questions, please go ahead and that haven't been answered, please go ahead and email them to my questions at cancerbridge.com. Otherwise, we'd just like to thank you and tell you to have a great day. Thanks so much.
Thank you.